You're listening to Who Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about dilated cardiomyopathies. Dilated cardiomyopathies include sarcoidosis, laminopathies, ARVC, PVC-mediated cardiomyopathy, tachycardia-mediated cardiomyopathy, peripartum cardiomyopathy, hemochromatosis, and Chagas cardiomyopathy. Dilated cardiomyopathies are those with EF of 40% or less with no evidence of ischemia, and echo findings with increased LV end diastolic volume, increased LV end systolic volume, and LV volume. You can also have global hypokinesis, normal wall thickness, and despite normal wall thickness, there is an increase in the LV mass and LV volume in dilated cardiomyopathy. Biatrial and biventricular chamber dilation is quite common in idiopathic dilated cardiomyopathy. Interestingly, the presence of segmental wall motion abnormality is common and predicts more favorable prognosis than global hypokinesis in dilated cardiomyopathy. Increase in LV mass is also a favorable prognostic variable in dilated cardiomyopathy, as it predicts a greater likelihood of improvement in LV systolic function. When somebody has idiopathic dilated cardiomyopathy with no known mutation in the family, you should do routine screening of first degree relatives every 3 to 5 years, including ECG and echo, even if there are no symptoms. The sphericity index represents the extent of chamber remodeling from a normal elliptical ventricular shape to an abnormal spherical shape. It is determined in end diastole and end systole. A normal ventricle has a sphericity index of at least 1 or higher. As the sphericity index approaches 1, meaning the ventricle becomes more spherical, there is apical displacement of the papillary muscles as a consequence of dilation. Improvement in the LV sphericity index in response to dobutamine is a predictor of late recovery of LV systolic function in idiopathic dilated cardiomyopathy. More spherically shaped ventricles have worse prognosis. Therefore, if the dobutamine makes the ventricle less spherical, that predicts a greater likelihood of the ability to reverse remodel. Let's start with sarcoidosis. Sarcoidosis is a systemic disease with formation of small clusters of immune cells called granulomas in various organs, including the heart. In cardiac sarcoidosis, the myocardium has scar due to infiltrating non-caseating granulomas. The scar tissue may lead to heart block, syncope, or sudden cardiac death. Sarcoidosis involves the lungs in 90% of patients and the heart in 1/4 of patients. FDG uptake on PET scan indicates active inflammatory sarcoid lesions as inflamed macrophages in sarcoid granulomas avidly uptake glucose. A high-fat, low-carbohydrate diet or fasting for at least 12 to 18 hours is essential to suppress normal myocardial glucose uptake, enhancing the contrast between normal tissues and inflamed areas. Normal myocardium will have minimal FDG uptake if preparation is done correctly. Areas of increased FDG uptake represent active inflammation. Sarcoidosis can have the following features on echo: globally hypokinetic LV, regional wall motion in a non-coronary distribution, increased wall thickness due to edema or infiltration, increased echogenicity, usually of the septum and free wall, related to scar formation and formation of non-caseating granulomas, abnormal LV, global longitudinal strain, but in a non-cherry on top distribution, dilated or restrictive cardiomyopathy, thinning and akinesia of the basal septum with normal distal or apical septum, aneurysm of the inferolateral wall, small pericardial effusion, mitral regurgitation or tricuspid regurgitation secondary to papillary muscle dysfunction, pulmonary hypertension, and RV involvement. These are the features of sarcoidosis that can be seen on echocardiogram. The criteria with higher specificity are a dilated cardiomyopathy with a non-coronary wall motion abnormality, EF less than 50%, thinning of the basal ventricular septum, and aneurysms involving the posterior lateral basal wall and apex. Contrast the thinning and brightness of the basal septum in sarcoidosis, which is a dilated cardiomyopathy, with the thinning and brightness of the basal inferolateral wall in Fabry's disease, which is a hypertrophic cardiomyopathy. When we talk about thinning of the basal septum in sarcoidosis, this refers to thinning of the basal anteroseptal and basal inferoseptal walls. The mid-anteroseptal and mid-inferoseptal segments should have normal thickness. Although commonly present, diastolic dysfunction, pulmonary hypertension, and pericardial effusion are nonspecific findings. Severely increased wall thickness is a rare finding in cardiac sarcoidosis. It's much more common for cardiac sarcoidosis to present as a dilated cardiomyopathy than a restrictive cardiomyopathy. CMR of sarcoidosis will show mid-myocardial and epicardial late gadolinium enhancement, i.e., sparing of the endocardial border, particularly in the basal septum and basal lateral wall. T2 imaging can also detect active inflammation in some cases. Gallium 67 scanning for inflammation imaging was previously used to confirm pulmonary sarcoid. This has been supplanted by computed tomography and FDG-PET, both of which have better sensitivity and specificity as well as lower radiation exposure. Biopsy of cardiac sarcoidosis would show non-caseating granulomas. Bilateral perihilar and right paratracheal lymphadenopathy, lambda sign, suggests pulmonary sarcoid involvement. ACE levels are elevated in 60% of patients with sarcoidosis, but that test has low sensitivity and specificity. What does the 2017 AHA-ACC HRS guideline for management of ventricular arrhythmias and the prevention of sudden cardiac death say about sarcoidosis? In patients with cardiac sarcoidosis who have sustained VT or are survivors of sudden cardiac arrest or have an LVEF of 35% or less, an ICD is recommended if meaningful survival or greater than 1 year is expected. That's a class 1 recommendation. In patients with cardiac sarcoidosis and an LVEF greater than 35%, it is reasonable to perform an electrophysiological study and to implant an ICD if sustained ventricular arrhythmia is inducible, provided that meaningful survival of greater than 1 year is expected, class 2A. In patients with cardiac sarcoidosis who have an indication for permanent pacing, implantation of an ICD can be beneficial, class 2A. In patients with cardiac sarcoidosis with frequent symptomatic ventricular arrhythmia and evidence of myocardial inflammation, immunosuppression in combination with antiarrhythmic medication therapy can be useful to reduce the ventricular arrhythmia burden. Class 2A. Sarcoidosis. Now we'll move on to laminopathies. Lamin AC refers to the LMNA gene, which encodes nuclear envelope proteins lamin A and lamin C. These proteins are essential for maintaining nuclear structural integrity and regulating gene expression. Mutations in the LMNA gene are associated with a group of diseases known as laminopathies, which can affect skeletal muscle, cardiac muscle, and cause premature aging. The three main consequences of laminopathies in cardiology are dilated cardiomyopathy, conduction abnormalities, including sinus, bradycardia, first degree AV block, and complete heart block, and sudden cardiac death from ventricular arrhythmias, tachyarrhythmias. These are the three main cardiac consequences of laminopathies. Lamin AC mutations, which are autosomal dominant, first causes atrioventricular block, including complete heart block or ventricular arrhythmias, before causing dilated cardiomyopathy. So if you have somebody who comes with dilated cardiomyopathy from lamin AC mutations, you know that they must have had an arrhythmia preceding this already. LMNA cardiomyopathy presents early in life, with cardiac manifestations typically appearing in the 20s to the 40s. Sudden cardiac death may unfortunately be an initial presentation of lamin AC mutations. The cardiac conduction abnormalities progress to dilated cardiomyopathy at about 9% per year. What does the 2018 AHA-ACC HRS guideline on the evaluation and management of bradycardia and cardiac conduction delay say about permanent pacing and laminopathies? In patients with lamin AC gene mutations, including limb girdle and Emery-Dreifuss muscular dystrophies, with a PR interval greater than 240 milliseconds and left bundle branch block, permanent pacing with additional defibrillator capacity if needed, and meaningful survival of greater than 1 year is expected is reasonable. That's a Class 2A recommendation. What about the 2017 AHA-ACC HRS guidelines for the management of ventricular arrhythmias and prevention of sudden cardiac death? What does that say about ICD placement in laminopathies? In patients with non-ischemic cardiomyopathy due to lamin AC mutation who have 2 or more risk factors among NSVT, non-sustained ventricular tachycardia, LVEF less than 45%, non-missense mutation, and male sex, an ICD can be beneficial if meaningful survival of greater than 1 year is expected. That's a Class 2A recommendation. Now we'll move on from laminopathies to ARVC. Arrhythmogenic right ventricular cardiomyopathy is characterized by fibrofatty ventricular replacement, ventricular arrhythmias, and high risk of sudden cardiac death. The right ventricle is weak in ARVC because there is not much muscle. It has been replaced by fat. The EKG in ARVC will show T wave inversions in the anterior precordial leads, right bundle branch block, and high frequency, low amplitude deflection at the end of the QRS complex in many leads, called epsilon waves. That is highly testable. Early ARVC may be asymptomatic. As disease progresses, arrhythmias and RV dysfunction become more prominent. Symptoms of ARVC include palpitations due to ventricular arrhythmias, syncope, often exertional or arrhythmic, heart failure, and sudden cardiac death, especially in young athletes. Additional left ventricular involvement by ventricular ARVC occurs in advanced cases. In peristernal short axis, the RV outflow tract should be less than 3.6 centimeters in diastole in normal hearts in terms of its diameter. If there is RVOT dilation in a young person, then you need to consider ARVC. Echo of ARVC will show RV dilation, RV akinesia or dyskinesia, RV aneurysm formation, especially in the apex of the RV, which is a region called the triangle of dysplasia, reduced RV fractional area change of 33% or less, thin-walled RV due to fibrofatty replacement of the RV wall. These are the signs of ARVC that you can see on echo. How about CT scan of ARVC? The CT scan will show a dilated right ventricle and aneurysmal bulging of the RV free wall with a scalloped appearance. Complete avoidance of competitive sports and strenuous physical activity should be recommended to ARVC patients to reduce the risk of sudden cardiac death. There is actually no AHA-ACC guideline that definitively gives a recommendation about whether patients with ARVC need to have an ICD. However, this was well delineated by an international task force on ARVC in 2015 with their own class of recommendations. Class 1 indications where ICD is indicated in patients with ARVC are aborted cardiac arrest, sustained ventricular tachycardia, severe left or right ventricular dysfunction, meaning right or left ventricular ejection fraction of 35% or less, or right ventricular fractional area change of 17% or less. This category is associated with an annual serious adverse event risk of 3.8%. Again, aborted cardiac arrest, severe LV-RV dysfunction, and sustained ventricular tachycardia. These are class 1 indications for placing ICD in a patient with ARVC. How about class 2A indications where, quote, ICD should be considered? These are syncope, non-sustained ventricular tachycardia, moderate LV or RV dysfunction defined as EF of 36 to 40% on the right ventricle, or EF of 36 to 45% in the left ventricle, or RV fractional area change of 18% to 24%. This category, the class 2 indications where ICD should be considered, is associated with an annual serious adverse event risk of 4.2%. Now, what about class 2B indications where ICD may be considered? ICD may be considered in the presence of any of these minor risk factors: young age, but they don't specify an age cutoff in the document, male gender, proband status, T wave inversions in precordial leads or inferior leads, QRS fragmentation, QRS precordial amplitude ratio, programmed ventricular stimulation inducibility, electroanatomic mapping showing scar or fragmented electrograms. This category is associated with an annual serious adverse event risk of 0.8%, for which ICD may be considered. Then, class 3 is the situation where ICD is not indicated. These are low risk patients with an annual serious adverse event risk of 0%. And this only refers to those with no risk factors, including healthy gene carriers of ARVC. That's class 3, where ICD is not indicated. Can athletes with ARVC participate in competitive sports? According to the AHA-ACC 2015 scientific statement on eligibility and disqualification recommendations for competitive athletes with cardiovascular abnormalities, athletes with a definitive borderline or possible diagnosis of ARVC should not participate in most competitive sports, with the possible exception of low-intensity Class 1A sports, Class 3. Prophylactic ICD placement in athlete patients with ARVC for the sole or primary purpose of permitting participation in high intensity sports competition is not recommended because of the possibility of device related complications. That's a class 3 indication. Now we'll move on from ARVC to PVC mediated cardiomyopathy. How do premature ventricular contractions lead to cardiomyopathy? There are several ways: post extrasystolic potentiation, LV dysynchrony, and AV dysynchrony. Post extrasystolic potentiation refers to the increase in contractility that follows either an atrial or ventricular extrasystole associated with a calcium overload. There's an increase in O2 consumption, reduction in LV-EDP, mean of 13, and increase in coronary flow after each PVC. Then LV dysynchrony, uncoordinated contraction of the LV segments, cause disruption and progression of dyssynergic LV wall motion, resulting in LV dysfunction. This is directly proportional to the PVC coupling interval. Longer PVC coupling intervals, meaning late PVCs, demonstrate a greater LV dysynchrony. And then you also have AV dysynchrony. This occurs when atrial contraction takes place against a closed AV valve during a PVC, demonstrated as a prominent A wave in a pulmonary capillary wedge pressure tracing. Because of this, post extrasystolic potentiation, LV dysynchrony, and AV dysynchrony, that is how PVCs, which are seemingly harmless, can actually lead to cardiomyopathy that can be quite serious. A PVC burden of 10% and up is usually required for the development of PVC cardiomyopathy. Is it possible for somebody to have both diastolic AR and systolic AR if they have PVCs? Yes. What is systolic AR? AR being atrial aortic valve regurgitation. So normally aortic valve regurgitation, as you would think, occurs in diastole since the aorta opens during systole. But there's a concept called systolic aortic regurgitation. In patients who have frequent PVCs, since the PVC may not be able to generate adequate forward flow in systole, the pressure remains higher in the aorta than in the LV. So the AR that started with the diastole of the prior normal beat continues through systole of the PVC, although with an interruption of the Doppler flow. Systolic aortic regurgitation can also occur with atrial fibrillation with varying cycle lengths and pulses alternans. What does the 2017 AHA-ACC HRS guideline for management of patients with ventricular arrhythmias and the prevention of sudden cardiac death say about PVC-induced cardiomyopathy? For patients who require arrhythmia suppression for symptoms or declining ventricular function suspected to be due to frequent PVCs, generally more than 15% of beats and predominantly of one morphology, and for whom antiarrhythmic medications are ineffective, not tolerated, or not the patient's preference, catheter ablation is useful. That's a class 1 recommendation for PVCs. In patients with PVC-induced cardiomyopathy, pharmacologic treatment, for example, beta blocker or amiodarone, is reasonable to induce recurrent arrhythmias and improve symptoms and LV function, class 2A. Now let's move on from PVC-mediated cardiomyopathy to tachycardia-mediated cardiomyopathy. Tachycardia-mediated cardiomyopathy is characterized by a dilated cardiomyopathy with a moderate to severe biventricular systolic dysfunction and lack of hypertrophy. Mitral insufficiency may be present. Technically, a true definitive diagnosis of tachycardia-cardiomyopathy can only be established after recovery or improvement of LV systolic function within the first 6 months after eliminating the culprit tachycardia. In tachycardia-mediated cardiomyopathy, which is dilated, if recovery of LV function occurs after successful cardioversion, a recurrent episode of AFib or aflutter will actually not be well tolerated. It will cause a rapid decline in LV function. Chronic right ventricular pacing may result in development of heart failure occurring in 12% of patients who are paced more than 20% of the time. There's also a related entity, pacemaker-mediated tachycardia and pacemaker-related cardiomyopathy, which I will cover in the separate episode in the arrhythmia section. Now let's move on to peripartum cardiomyopathy. Peripartum cardiomyopathy is a dilated cardiomyopathy defined as development of heart failure symptoms with an LVEF less than 45% and no other identifiable cause of heart failure during the last month of pregnancy or during the first 5 months postpartum. It more commonly occurs in the months after delivery than before delivery. It is also more likely to occur with older maternal age, multiparity, and presence of preeclampsia. Echo of peripartum cardiomyopathy will show decreased biventricular function without focal wall motion abnormalities. Anticoagulation is needed for peripartum cardiomyopathy if there's ejection fraction less than 30% or use of bromocriptine. What do we need to know about heart failure medications during pregnancy that we would give to peripartum cardiomyopathy? Beta blockers are safe throughout pregnancy and postpartum or lactation. ACE inhibitors, ARBs, ARNIs, SGLT2 inhibitors, MRAs, and ivabradine cannot be used during pregnancy. Hydralazine, nitrates, and diuretics are safe during pregnancy. During postpartum or lactation, ACE inhibitors such as enalapril or captopril can be reintroduced, as can be MRA. There is not yet enough data about ARNI and SGLT2 inhibition during postpartum or lactation, but hopefully that will change in the coming years. 50% of peripartum cardiomyopathy patients fully recover with normalization of LVEF and resolution of symptoms. Subsequent pregnancies should be discouraged after peripartum cardiomyopathy because of a high likelihood of relapse. Even patients who recovered from an episode of peripartum cardiomyopathy have a 30% risk of experiencing relapse of peripartum cardiomyopathy during subsequent pregnancies. In a small series of patients who recover from peripartum cardiomyopathy, if dobutamine stress echocardiography shows normal contractile reserve stroke volume increasing by at least 15 to 20% with dobutamine, that indicates they have lower risk of recurrence of peripartum cardiomyopathy. Now let's move on from peripartum to hemochromatosis. Hemochromatosis is usually a dilated cardiomyopathy, but it can also show up as a restrictive cardiomyopathy. Hemochromatosis is most commonly inherited as an autosomal recessive disorder with a mutation in the HFE gene that encodes the transmembrane protein responsible for regulating iron uptake in the intestine or liver. Other than hepatomegaly, elevated LFTs, hyperpigmentation, hemochromatosis also has hypogonadism, central hypogonadism from iron deposition in the pituitary gland, arthritis of the MCPs, wrists, hips, and knees, cardiomyopathy, and diabetes. Hypothyroidism can also cause arthralgias and reduced libido, but does not cause glucose intolerance or elevated LFTs. So, if a patient presents with erectile dysfunction, testicular atrophy, low serum testosterone, and low gonadotropin levels suggesting secondary hypogonadism, consider hereditary hemochromatosis if he has elevated LFTs, hepatomegaly, hyperpigmentation, diabetes, and especially dilated cardiomyopathy, or less commonly, restrictive cardiomyopathy. What are the expected levels of iron levels in hemochromatosis? Iron normally is 60 to 160 micrograms per deciliter. In hemochromatosis, iron will be modestly elevated to 180 to 300 micrograms per deciliter. Ferritin is normally 15 to 200 nanograms per milliliter. Ferritin will be elevated 250 to 3000 in hemochromatosis. Transferrin saturation percent is normally 20 to 50%. Transferrin saturation will be 45% to 100% in hemochromatosis. Just remember that in hemochromatosis, all the iron labs are high in the panel. It's easy to remember. Most of all, if the transferrin saturation is more than 55%, then it's hemochromatosis. Hemochromatosis will have a mildly dilated LV cavity with global LV dysfunction. Since hemochromatosis is not an infiltrative disorder, the wall thickness is not significantly increased. LV wall thickness will be normal or mildly increased. In early stages of hemochromatosis related cardiomyopathy, diastolic dysfunction may be the first manifestation despite normal LV size, wall thickness, and systolic function. As disease progresses, there will be a decrease in LV systolic function, LV cavity dilation, and biatrial enlargement. A restrictive filling pattern is a late manifestation when there is LV dysfunction. Treatment with chelating agents or phlebotomy can improve cardiac function. ECG of hemochromatosis can show diminished voltages and sometimes atrial fibrillation. On T2 weighted images of cardiac MRI, hemochromatosis will have a dark liver and dark myocardium, decreased signal intensity. T2 time will be less than 20 milliseconds if there is hemochromatosis. This indicates cardiac siderosis. Remember that ground glass sparkling characteristic of the myocardium on echo is a finding of amyloidosis, not hemochromatosis. Don't confuse the two. Ground glass sparkling characteristic myocardium on echo is amyloidosis. Now back to hemochromatosis. Endomyocardial biopsy is almost never needed to make the diagnosis of hemochromatosis given the high accuracy of cardiac MRI findings. Endomyocardial biopsy is more commonly used to confirm other conditions such as giant cell myocarditis or cardiac amyloidosis. Now we'll move on from hemochromatosis to talk about Chagas cardiomyopathy. Chagas cardiomyopathy, which is more often seen in South America than in the United States, actually starts out with a normal LV cavity size when it has its classic apical aneurysm, infralateral wall motion abnormality, and LV thrombus. That triad is important. RV aneurysms and biventricular aneurysms have also been reported, but this is primarily a left ventricle disease. Later on, when the Chagas disease patient develops symptoms and EKG findings such as right bundle branch block, left anterior hemiblock, AV block, or multifocal PACs, that is when they progress to a dilated cardiomyopathy. Chagas cardiomyopathy, once again, I'll remind you, is dilated, can also have thinning and brightness of the basal infralateral wall, just like in Fabry's disease, which is a hypertrophic cardiomyopathy. Okay, remember that thinning and brightness of the basal septum is in sarcoidosis, whereas thinning and brightness of the basal infralateral wall is Fabry's disease, which is a hypertrophic cardiomyopathy, and can also be Chagas disease. Okay, basal infralateral wall thinning and brightness can be Chagas disease or Fabry's disease. That is everything that I wanted to go over for dilated cardiomyopathies.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.